Hello, my name is Farrah Liu, PGY2 from Stanford University. Thank you for the opportunity to present today. I have no disclosures. Significant advances in microsurgical techniques have led to high success rates after microsurgical breast reconstruction. However, thrombosis-associated flap failure is still a devastating complication that occurs in 1 to 3% of all cases. Currently, there are no consensus guidelines that exist regarding pharmacological prevention of microvascular thrombosis following free tissue transfer. Many regimens have been proposed, including combinations of aspirin, heparin, and colloids, which all come at the price of increased bleeding-associated complications. While the use of aspirin to prevent thrombosis has been effectively demonstrated in rat models and is commonly prescribed by many microsurgeons, this practice has not been supported by clinical evidence. The goal of our study was to investigate the impact of postoperative aspirin administration on clinical outcomes following microsurgical breast reconstruction. A prospectively maintained database of 2 surgeons was queried to identify patients who had undergone microsurgical breast reconstruction. Patients were categorized based on whether they had received postoperative aspirin for 30 days, Group 1, or had not received aspirin, Group 2. Patient demographics, as well as reconstructive outcomes, flap types, complications, and transfusion requirements were collected. A total of 136 patients with a mean age of 49.5 years and a mean BMI of 28.5 underwent 216 autologous breast reconstructions with free abdominal flaps were included in this study. 81 patients received aspirin postoperatively, whereas 55 patients did not. There were no differences in age, BMI, presence of any comorbidity, and type of mastectomy seen between the 2 study groups. A significantly higher rate of neoadjuvant chemotherapy, delayed reconstruction, longer follow-up, and greater length of stay was noted in Group 1. No difference was noted regarding the number of unilateral and bilateral reconstructions or in regards to flap types, as seen in the tables. 3 patients in Group 1 and 2 patients in Group 2 developed a breast hematoma, which required surgical evacuation. Other complications, including partial flap necrosis, mastectomy skin necrosis, and breast seroma, did not differ significantly between the 2 groups. Patients in Group 1 had more wound complications at the abdominal donor site. However, statistical significance was not reached. No significant differences were found for postoperative abdominal bulge or hernia formation. 1 patient in each group developed a DVT. Blood transfusions were administered for a hematocrit of less than 21, without any significant difference in transfusion rates being noted between the groups. Also, no difference in the pre- to post-operative hematocrit change was noted between study groups. In our analysis of 216 autologous breast reconstructions, the addition of aspirin to post-operative subcutaneous heparin did not prevent complications compared to heparin alone. None of our patients developed microvascular thrombosis of the flap pedicle, and deep venous thromboses occurred in only 1 patient per group. Given the lack of clinical benefit and the potential risks associated with aspirin administration, our data do not support the practice of routine postoperative aspirin administration following microsurgical breast reconstruction. Thank you all for listening, and a special thank you to my co-authors and mentor, Dr. Momeni.